Welcome to the Q&A for Managing Recurrence. Dr. Wethington will now get this Q&A started.
Hi, everybody. Thank you for joining us this evening or this afternoon, I guess, depending on what part of the country you're in today. I am a GYN oncologist based out of Baltimore, Maryland at Johns Hopkins, and I direct our survivorship program here at Johns Hopkins. And I don't know if any of you have come to OCRA before, but I was saying actually while we were in the waiting room that this is one of my favorite things to do all year, and this Q&A in particular. So I just always enjoy this conference. I think everybody gets so much out of it, and I even enjoy listening to my colleagues give some of the talks. So I'm glad everybody has joined us tonight and throughout the conference. So there are a couple of different mechanisms through which we can do this. I have a list of questions that some folks submitted in advance of today's session. So I'll start off with those. And then in addition to that, there's the chat box. And I find just from doing this in the past that the chat box is a really nice way to get your questions in. I actually can monitor, it's up in the dead center of my screen right now. So I can monitor it while we go and integrate and overlap responses. So if I say something that triggers a question, feel free to pop the question in there and I'll try to just wrap in my answer as I go. So welcome everybody. Hopefully you brought some questions. If not, I'm going to start off with the questions that the team from OCRA has sent me and asked me to start off with. So I'll start with those. The first one I think is probably, it shows up, I should say, in multiple questions. So multiple people sent in a question asking about PARP inhibitors, indications for PARP inhibitors, when to have PARP inhibitors, who benefits from PARP inhibitors, whether you can get a PARP inhibitor a second time. So lots of good PARP inhibitor questions. I think it's a real hot topic. So we'll start right there. So currently in 2021, the indications for PARP inhibitors are predominantly in the maintenance setting, meaning you've received a combination of a platinum and another agent, a doublet, 2 drugs. You have good response to those or complete response to those. And then we use the PARP inhibitor as maintenance to keep the cancer away. That's the majority of indications. And those indications can be in the upfront setting, meaning first diagnosis, and they can be in the platinum-sensitive recurrent setting. And then there's some indications for folks who have a BRCA mutation, which is the inherited risk of ovary cancer related to BRCA. For those folks, there's also an indication in the treatment setting if you've received prior therapies. So there's a number of different indications, but probably the biggest place we see it used today, not probably, definitely, is in the maintenance setting and more in the primary setting. So at initial diagnosis, the technical recommendation is that it is available to anyone, whether you have a BRCA mutation or not. Sometimes it can be given in the upfront setting by itself, either olaparib or niraparib, for instance, being the 2 most common, or olaparib with bevacizumab, for instance, for folks who have BRCA mutations. So those are some of the core moments in the upfront maintenance setting. In the platinum-sensitive recurrent setting, it's open to anybody and everybody, regardless, and actually 3 drugs. So anybody and everybody, 3 drugs as options: olaparib, niraparib, and rucaparib. So all 3 of the PARP inhibitors in that setting. So lots of options, lots of different time points in the primary setting and in the recurrent. And somebody asked for how long can it suppress recurrence? And the good news is we don't know actually for how long. We don't have an end time, but it can suppress recurrence anywhere from a short number of months, 5 months, up to an ongoing timeline for some patients, but on average, measured in years actually, and no longer in months, 3, 4, 5 years for some patients. And some patients are still on them, so we don't know the answer. So there's a lot of hope with regards to the use of PARP inhibitors and their potential, and the fact that we haven't fully captured their full impact in the maintenance setting and that we're still learning. You can actually reuse, we're getting more data. We don't have perfect data yet, but we are getting more data, and this was one of the questions, on using PARP after progression on PARP. So you're on PARP maintenance therapy, and I don't know if anybody saw, but the Oreo trial, it has a great name, like an Oreo sandwich. The Oreo trial just had some results presented. We don't have the paper yet, so we can't review all the details, but there was an oral presentation just a few weeks ago, I think 2 weeks ago, and it showed that there is a role for reusing PARP inhibitor once you've been on it, progressed, gotten more platinum-based chemotherapy, and then going back on the PARP inhibitor. So, so there is now new data that says we should consider potentially reusing PARP inhibitor. And I think that question of reusing PARP inhibitor, the data is going to evolve. This is the earliest data. It's actually kind of the first data that says, hey, there's a signal here, we may be able to do that. There's lots of data, not lots, there's an increasing amount. I say lots because it's better than none. So to me, it feels like lots. There's increasing data on pairing PARP inhibitor with other drugs like WEE1 inhibitors or ATR inhibitors. Some folks are looking at pairing PARP inhibitors with VEGF inhibitors or immunotherapies. So a variety of different combination strategies, and that data is also slowly trickling out. So there's PARP after PARP as a concept is being hotly investigated. And so that's one option. If you use the olaparib with the Avastin, for instance, in the upfront setting, there is now increased data that you don't need to continue the Avastin indefinitely. And there's different timelines for how long to continue it after the 6 cycles of carboplatin and paclitaxel that most people are taking it with. But somewhere certainly in the range of an additional, 15 cycles is not atypical. So sort of up to the 2-year timeline, sometimes a little longer. But you don't need to necessarily continue the Avastin indefinitely, and that's newer data that's coming out. So these are all options. Now, somebody asked, okay, PARP inhibitors are great. I mentioned PARP inhibitors can be used by everybody, regardless of BRCA status and HRD status at different time points. And somebody, more than one person, has asked about if you don't have a BRCA mutation and you aren't HRD, what are the treatment options besides Avastin and chemotherapy, or what are the latest treatment options? And I think this is a very good question and a hard question. We're looking at a variety of strategies for patients who do not have BRCA mutations or HRD, but there is no new approval or combination that has come out in the last year for this cohort. There are ongoing studies, certainly, and so clinical trials, but no current new drug that's come out recently that I could say that I could point to. There are a laundry list of chemo drugs available for a recurrence in the non-HRD, and you all have probably heard the names gemcitabine, Doxil, pemetrexed, venerelbine, the list goes on and on. So certainly there's a lot of options in the chemotherapy realm, but for the non-BRCA, non-HRD cohort, in terms of targeted therapies, we don't have a targeted agent unless, let's say, you had a mutation in another gene, and maybe one of the basket trials or another targeted agent based on a gene mutation you had would be available. The Oreo trial, that PARP after PARP trial that I mentioned, it did actually allow, interestingly, both the use of the reuse of olaparib as well as prior niraparib, rucaparib, or volaparib, actually. So it was in many cases, the majority, reuse of the same PARP. So that is one possibility and one feasibility. So let me see real quickly, scanning through. Oh, someone asked a recurrent granulosa cell tumor question. I'm so glad you asked this because anybody heard my recurrent talk, they know I said, gosh, we always get in this habit of talking about high-grade serous ovarian cancers. And it is not because there aren't other ovary cancers. There are other ovary cancers. There's germ cell tumors, there's sex cord stromal tumors, there's high-grade ovary, there's low-grade ovarian serous, there's endometrioids, there's a bunch of different histologies. And I do it, and I actually start every talk, and I didn't start this talk with my apology, because I also fall into the ovary cancer is serous cancer trap. I also say ovary when I mean ovary, primary peritoneal, or fallopian tube, but goodness, that would just take up the entire talk. So we can't do that. So, so granulosa cell tumors, I would say, unfortunately, we don't have any new latest and greatest in this category. Oftentimes, actually more than drugs, we use surgery and surgical resection, because granulosa cell tumors tend to grow slowly and indolently. They sort of sneak in and they slowly get bigger and bigger. And so, so certainly surgery is a primary mainstay of treatment, actually even more so than drug therapy or treatment in that regard. Now, someone asked about, to kind of change the subject here a little bit, someone asked about imaging. And I think this is a really good question, because some people get PET scans, some people get CT scans, some people get CA-125s. So what are all these things and how do they factor in? And that was one of our questions also about CA-125 and what is CA-125 and what's its role. So what study you use, CT scan versus PET scan, I want to start by saying there's no right answer. So some docs tend to recommend CT scans, some docs tend to recommend PET scans. Those of us, myself included, who tend to lean towards CT scans because that's the primary imaging modality used in most studies. CT scans look at structure. So they're looking for masses, growths, tissue abnormalities, anatomic abnormalities, something that would hint to us that there's a recurrence or a growth of a known recurrence if you're in the setting of following somebody who's on treatment. And this CT scan has been the mainstay for many, many years of all of our clinical trials. And so when do you change regimens, we sort of think of in terms of size changes or new lesions on CT scan. PET scan looks at the release of, or the utilization of glucose in cells. And so at the cellular level, cancer cells, infectious cells, or cells that have an infection going on, they all have an elevated uptake of glucose. So the PET scan tells you about the glucose uptake in the cells in that area. And so some people will use language like, well, a PET scan is more sensitive than a CT scan. I don't know, my CT scan folks are finding things for me that are like 3 millimeters, and then my PET scan folks are saying it's below the resolution of a PET scan. So I think that might be a little bit in the eye of the beholder sometimes. The PET scan, some folks lean towards because it can, when you're looking at certain areas of the body and anatomic relationships are not perfectly crisp on a CT scan, the PET scan will sometimes pick up things. Or when we have a vagary, and we say on the CT scan, unclear or unknown or indeterminate finding, we can then use the PET scan to further clarify. Or if we're really worried about something and we get a CT scan and it doesn't show anything, we can get the PET scan as like an extra double check. So PET versus CT, there's no right or wrong. They're looking at slightly different things. They're not looking at exactly the same thing, and they can actually be complementary. So you can use the PET to augment what you're getting out of the CT. You can use the CT to figure out what it is that's lighting up on PET. So those are helpful. Those can be very helpful. In some settings, an MRI can also be extremely helpful. MRI looks at a much tighter tissue definition. And so your MRI can show you or tell you about the relationship. Is something invading into something else at a much finer detail level? And so sometimes we'll use MRI, generally speaking, we'll use MRI certain parts of the body. MRI is much better. Your brain MRI is much better. Oftentimes the spine, the MRI can be much better. And so we'll use MRIs in certain anatomic structures where it can be much more, very helpful. We don't use it generally for screening studies, meaning let's say you're on carboplatin and paclitaxel, you've gotten 3 cycles and you want to know whether or not the tumor has responded to those 3 cycles. MRI, you don't need an MRI for that. You don't need that level of detail. And frankly, as a patient, an MRI is really loud. It's really tight. It's a tight space, and it takes a very long time. So the added benefit in terms of clinical decision making, except in a limited number of circumstances, is not as much there, and so we tend not to use it. And they're always extenuating circumstances. There's virtually nothing I ever say that's absolute. So sometimes allergies and other things we can use MRI for. And somebody asked about radiation exposure, and the truth is the CT scans today are modified dosing, and so the radiation exposure is actually very low. And in general, we tend not to be as aggressive, and aggressive, I mean, frequent in our CT scans as we may have been in the past a little bit. And so I think the radiation exposure is not anything to worry about. And I say that once upon a time, I had a patient who was on a clinical trial and doing very well. And so I calculated out the radiation exposure, trying to argue that she shouldn't have to get CT scans anymore. And then you have to get every 8 to 12 week CT scans for 5, 6, 7 years before your dosages are such where you see appreciable changes in other cancer risks. And those situations where you're getting CT scans are very rare, and even that risk might be measurable, but it doesn't mean it's big. It's like a minuscule risk. So I think the radiation from CT scans, given their indication, is nothing to fret or worry about. So that's what I would answer there. Now, tumor testing. Somebody asked about one company in particular. There are many companies that do tumor testing. So there's different kind of testings we can do. The first kind of testing that everybody with an epithelial ovarian cancer should have is genetic testing. That's the stuff you inherit from your parents. That's the stuff that if you have children, you could pass on to children. If you don't have children, it's the stuff that your siblings might have and their children might have, or your cousins might have. So even if you don't have children, and there are others potentially in your life who may benefit from having that information. So genetic testing is testing the inherited components. When we talk about BRCA1, BRCA2, we think about Angelina Jolie's talked very publicly about this. So I use her only because she's talked about it, so there's no HIPAA there, but it's inherited. We know her mom and her grandmother both had cancers, and that's how she found out about it and took measures. And that's why it's important to get tested, because it A, helps your family, and B, helps you. You know whether you need any additional cancer screenings related to perhaps breast cancer, whether treatment options, maybe you should push a little bit harder to think about PARP in the upfront setting if you have a germline mutation. Those folks really seem to benefit. So it's important information for you and your family. That's germline. Somatic testing. There's multiple companies that do somatic testing. There are multiple institutions that do somatic testing in-house, is what it's called. So they have their hospital-based or university-based or cancer center-based tests that they do in-house. Whichever one you get, what these tests are doing is they're looking at the tumor and they're testing the tumor. And they can test the tumor for a couple different things. They can actually look at the genes themselves and the sequences in the genes, and they can see if there are any mutations. And those mutations could be related to the underlying pathophysiology of the cancer. So they look at the actual genes and the sequencing. They can look for proteins and how proteins function. So they have a number of different sort of possibilities of what the different testings look for. They can look for rearrangements in some rare tumor types and other things. So that testing helps also. It helps categorize likelihood of benefit from PARP inhibitors. Sometimes it'll find a rare mutation that may be targetable. So maybe you're someone who has a mutation where there's a clinical trial, and you should think about perhaps that clinical trial. So the tumor testing is helpful in the upfront setting so that you can have a sense of what your benefit might be from PARP inhibition. It's helpful in the recurrent setting. Again, helps you know your likely benefit from PARP, but also helps you know about clinical trials and other targeted agents and other things you might consider. And so that somatic testing doesn't tell you about the inherited risks or your family members. That somatic or tumor testing is really about you and your treatment for the cancer that you have at that point in time. There's also HRD testing. And HRD is very tricky because HRD stands for homologous recombination deficiency. And it is a phrase to indicate, does the cell function to repair DNA properly? Does the homologous recombination process work? It is the most elegant repair mechanism that we have in our bodies for cells and DNA. And when it goes awry, 50% of ovarian cancers, it's not working. And when we test for HRD, we're testing for markers of the fact that it's not working. And it actually gets very complicated because we thought the markers were just testing for whether or not it's working. And now Like all things in science, as we understand them better, we understand that it's not always in the present. Sometimes it's in the past, which is why these things are not perfect markers, but good markers. But we know HRD also helps us split out who may or may not benefit from PARP inhibition. So that's why we always look at this, this information. So I want to come back, and we've got some questions here. I want to see if I can answer, and just give me one sec because they are. So this is a great question about the imaging that I didn't mention. One issue with imaging is that imaging is limited by the size of the lesion. So how might we monitor by things that are real small? And I'm going to bring back something I forgot to talk about. My mind kept going, and so I left it out, which is CA125. And so what I want to say about CA125 to get at the answer to this question is CA125 is a protein. It is an indicator of ovarian cancer for some women. So only 80% of ovarian cancers have a CA125 that you can follow over time. And its greatest utility is to know when a woman has a lot of the cancer inside her body, is the CA125 real high? Okay, so it's real high then. So we're going to follow it while she gets chemo. We're going to watch it come down. We're going to get a CT scan, and we're going to see that it's real low. Okay, that means that we can correlate clinically. We can think about the fact that the CA125 reflects how much cancer there is. And so we can use it as an indicator. We tend not to make major chemotherapy treatment changes based on a CA125 alone. We'll use a constellation of things, how someone's feeling, CA125, imaging, very important imaging. I haven't gotten it yet, so I'm just gonna assume that I'm gonna get it. Almost always somebody asks, if my CA125 is going up, but my CT scan is not changing, my doctor says I shouldn't do anything, but it's making me nervous. And I will say that CA125 is not a perfect marker. It's not always right. And sometimes it changes well before the CT scans change. So if your doctor ever says that to you, it's because they're waiting for that CT scan to change. We know that the CT changes are the things that we are most curious about. And actually somebody just put it and phrased it slightly differently. Can Avastin still be working if the CA125 is going up? And yes, you can be getting some benefit. It can be slowing things down. Maybe there's something percolating. I use that language a lot. Clearly something's percolating if your CA125 is going up, but you don't know what that is until it shows up on the CT scan. And so it can be real hard sometimes to wait, and there's a constellation of things you take into account when you're deciding to wait and watch the CA125. So it's not a strict calculation, but it is something we do sometimes do. So the CA125 can be an indicator of what's going on. And then when areas are real small and don't necessarily show up, it's a real challenge. And someone points out, like, let's say you go to the OR for a cholecystectomy. You're feeling totally fine. You have a little gallbladder trouble. You got gallstones. You go to the hospital because you have right upper quadrant pain, and sure enough, you've got gallstones. And you need your gallbladder out. And they go in to take out your gallbladder, and incidentally, they find an area of cancer. And it wasn't showing up on CT scans. I mean, this happens. Like, literally, we all have the story in our heads of somebody who goes in for something totally unrelated. And then, and they've had a CT like a month before, and then they find something. And so that raises a challenge because it means that our monitoring wasn't finding it, as this person says. And so what do? These are challenging circumstances and situations, and they're ones that require a good bit of conversation. And the language we use today is sort of shared decision making. You have to come to some agreement, and how you decide how to monitor after that depends on the specifics of the situation. Sometimes we say, if we can't see it and you're feeling well, then okay, right? And so it's really small and it's not bothering you. And so we're gonna go based on sort of patterns. So for instance, maybe you'll decide, I'm gonna wait until I'm not feeling well or something shows up on scan before I'm gonna do the chemo. Or I'm going to do the chemo and do the 6 cycles. We always do things in 3s and 6s and 9s and 12s. Those are patterns, everything in 3s. So there's a number of different ways to handle the scenario if you find recurrence at a surgery. It's an incidental finding. You weren't looking for it and it popped up, and what do you do now? And there's no single right answer. There's lots of considerations to take into account. What did they see at the time of surgery? How much was there? Did they remove it? And so there's no single way to make that determination, but it's an important sort of question for sure. Now, someone asked if you're HRD negative, maintenance. What are some maintenance options? And for the HRD negative, I want to say technically by FDA indications and approvals, you can use PARP inhibitor maintenance. So that is technically one answer. I think what you're getting at is that oftentimes gyn-oncs, even like myself, will say, well, the benefit for somebody who's HRD negative is less in the upfront setting. So let's sort of save it and use it later. PARP inhibitors and Avastin are the 2 standard maintenance options. When you're interested in an option and it's not available, I always recommend considering taking a search for a clinical trial. And there's a variety of places to look for clinical trials. Clinicaltrials.gov allows you to search every single open clinical trial in the United States and across the world. Actually, it's not just US. So there's clinicaltrials.gov. Actually, OCRA has a fabulous site and some assistance mechanisms for finding clinical trials. So you can check that out for sure. So that's another option. But if you're interested in pursuing a therapy and it's not currently a standard of care, I always recommend seeing if there's a clinical trial that fits into what you're interested in so that you could potentially enroll. And so that might be something to consider. Clinical trials, how are they structured? I just want to touch on this, and then this will get at a question somebody asked. Clinical trials are structured to answer a question. They're structured to answer a question that's designed with the thought that it will help us advance the science. And it's designed by one group of people and supervised by another group of people for safety. The safety monitors are the data safety monitoring boards, as well as the IRB, the institutional review boards. They set rules, they set guidelines, and they make sure that the clinical trials are running in a safe fashion. There can be phase 1, phase 2, phase 3, and actually phase 4 clinical trials. Phase 1 are really first in human or first combination. So maybe the drug's been used before, but now we're going to mix it with something else. And they're really about establishing toxicity information, getting dosing information so that you can move on to a phase 2 to get some beginning efficacy data. So your phase 2 gets you sort of efficacy data. And then phase 3 is a comparison. So phase 3 is where you look at, okay, this looks like it might be promising. We're going to compare it against a standard of care to see which is better. And phase 4 is once it's been approved, ongoing monitoring and studies, and in some cases, patient-reported outcomes. So for instance, I'm not sure if anybody on here tonight would possibly have a sarcoma, but there are some sarcomas that for which we use NTRK inhibitors and TRAC inhibitors, and there is a patient-reported outcomes study, which is a post-approval sort of phase 4 study going on. So there's a variety of different steps in that. Sometimes, particularly with phase 1 and phase 2 studies, biopsies will be done as part of the study. And sometimes some institutions, Hopkins included, we have tissue bank studies where we ask folks who are having surgery whether they'd be willing to donate their tissue and for research. And so somebody asked, well, can I have the reports? Can I see the results of that? The answer to that is going to depend on the consent form that you signed. So anytime biopsies are a part of a clinical trial, the consent form will include the parameters of what happens to the biopsy and whether or not you get the results back. I will tell you, I can't speak to this particular trial, but in general, when tissue is used for study, the results aren't released back to the patient because the tissue is held in confidence or anonymized. So it's not linked actually to you. So sort of as a way to preserve privacy. So if I were to sort of place a wager or a guess, my answer is you wouldn't be able to get the results back. But with 100% certainty that information is contained within the consent form that was completed. And so that's important information there. Great question. What's the difference between loss of heterozygosity and HRD? So loss of heterozygosity is one of the 3 tests that is included in the HRD assay that Myriad does. It is also one of the tests that a company called Foundation One does as their assay. So so in that sense, the terminology is used in different places for different purposes. When I referenced HRD earlier, I didn't mean an assay. I meant literally the process of homologous recombination and homologous recombination deficiency. And I think in this case, someone perhaps is getting at, well, I've seen results for LOH and I've seen results for HRD. What do they mean? And loss of heterozygosity is one marker of HRD and is also the way that Foundation One denotes sort of the loss of heterozygosity on the Foundation One test is how they denote the HRD. And whereas Myriad uses what they call an HRD assay. So a variety of things. There are clinical trials for everybody to get to this clinical trials question. There are clinical trials, sometimes hard to find, sometimes referred to as a needle in a haystack, to be honest, but there are clinical trials at every stage from initial diagnosis to many recurrent, many platinum sensitive recurrence. So there's a variety of possibilities in terms of clinical trials, definitely clinical trials for patients with recurrence. And in ovary cancer, that's often our most common set of clinical trials. So let's see, HRD testing is not done routinely. And it, in part because if you have a germline mutation or a somatic mutation, then you don't necessarily need the HRD. This is another thing we get into lots of conversations about. What should the sequence of germline, somatic, and HRD testing be? Should it be HRD first, then germline, then somatic? Should it be, somatic, then germline, then HRD? Sort of what should this sequence be? And there's a variety of different ways to do it. And so I wouldn't say it's done 100% of the time, but it is done often, particularly in settings where someone doesn't have a germline mutation and doesn't have a somatic mutation, and it would be helpful or relevant. So it's not always relevant. So sometimes we don't need it for other reasons. This is to continue on this HRD topic. If a PARP worked for me, should I assume I'm HRD positive? It's a interesting question. It would not be a wrong assumption. Now, there are probably people on here who would say, but I know I'm HRD negative and a PARP worked for me. So the assay is not a perfect assay. So you can be HRD negative and have a PARP work for you. And you can be HRD positive actually and have a PARP not work. So there's a variety of combinations that can happen there. But if a PARP worked for you, it would not be unreasonable to think that whether or not the HRD assay picked up the fact that you were HRD positive, there's some mechanistic reason why the PARP worked, and HRD is a good option or a good starting point of assumption. So let me see, I think I have got most of these. Somebody asked a question that I just need more clarification on. So if you're on, you can either direct message me or just send a chat to everyone. But someone asked about an ovarian cancer turning into a sarcoma, and they use it in initials UPS cancer and what to do about it. And I wasn't quite sure what the question was. So if that was you who posed that question, if you just send me a clarification of what you were asking, I will gladly answer it. That is not, I just wasn't quite sure. So does germline or somatic mean that someone is HRD positive or negative? If somebody has a germline BRCA mutation or a somatic BRCA mutation, yes, we assume they're HRD positive. That's the implication in that, because the BRCA 1 and 2, and I'm assuming that's what the germline and somatic mean there in that question. BRCA 1 and 2 are proteins that function in the process of homologous recombination. And when they are mutated, homologous recombination does not work. Thereby, there is an HRD, or a homologous recombination deficiency. Now, as I said before, it gets complicated because the more we learn, the more we know, the more questions we ask, the more we learn. So we do know that in the recurrent setting, someone with a BRCA mutation can have a reversion. Things can change within the tumor, and they can then, the cells can function as though they're HRD negative, but that sort of gets into the weeds of a growing area of research and science that we'll better understand in the future, and we don't yet have perfect information about yet. Hopefully soon. Somebody is off to an advocate leaders meeting, which I think is so great. I'm sure you've all heard about the different opportunities for advocacy, and hopefully everybody finds their own voice, whether it's like one-on-one with a single person you run into on the street or in public forums. I feel that it's such a unique opportunity for, for information disclosure and discussion. I have a couple masks that have the ribbons on them in various colors, and that's been my frequent during COVID, my favorite way to get a conversation started. It's amazing how many people ask me about it. PARP inhibitors and brain metastases, do they work? What a great question. We have very limited data, as you might imagine, because these are rare usage and scenarios. But there is some data to indicate that some PARP inhibitors do cross the blood-brain barrier. So our brains are designed to be protected. The blood-brain barrier prevents things from going into our brain. Any of you who's had a glass of wine thinks I can't possibly be right when I say that. But there is actually a mechanism there to protect our brains from chemotherapy. So a lot of chemotherapy drugs actually do not easily cross into the brain, but there is some evidence that some of the PARP inhibitors do work on brain metastases. So using a PARP inhibitor in this setting may not be unreasonable, depending on which one and what the setting is. So if that comes up, that's not an unreasonable question. Are there any studies showing off-label drugs being used along chemo to boost efficacy? Ongoing studies, well, there are studies. If you put the phrase in there, high quality studies, I would say I'm not sure there's high quality studies. This is a very, Colleen's name is up there, so I'm going to use it. Colleen asks an interesting and a very good question that we don't have perfect data to. There've actually been a variety of settings and drugs that are not used for their intended purpose that seem to have cancer benefits. So let me give you some examples. Actually, in endometrial cancer, metformin, right? We had for a period of time data that indicated that patients with endometrial cancer who were on metformin had improved outcomes compared to patients who weren't. And so we went down this path of seeing, well, what if we add metformin, and will that help folks who weren't on the metformin? And it turned out probably not. And it seems that what the metformin is doing is fixing something else that's impacting the outcome of the cancer. For instance, in this case, glucose management. In ovary cancer, I think the most common moment in which I get this is a regimen, and I'm forgetting the full regimen, but as soon as I start, someone is certainly going to remember. It's like mebendazole, a cholesterol lowering drug that I can't think of the name of. I think it's commonly called the COC regimen is what it's labeled. And it gets at this, it's off-label drugs. They have indications, and some people feel that they boost the efficacy of the chemotherapy or help people with malignancy. And I would say that the data is still out. There's some intriguing theories, but there's no clear data. And so I think this is a real challenge. I think what there is data to support, and so some of us sometimes wonder with some of these agents, since they do other things, right? They affect your gut microbiome with some of these drugs. Some of them are cholesterol lowering drugs. Some of them are sugar management drugs. So certainly good health, managing other medical issues you might have would be very helpful, and maybe what some of this is getting at. Vitamin C, turmeric, mistletoe, all of these are some integrative therapies that folks ask about and sometimes use. I think all of them can be used safely in combination. There is not definitive data or comprehensive data yet, but in these, especially with mistletoe and vitamin C and the turmeric, growing data to indicate when they should or shouldn't be used. If you're going to use them, please know they're natural, but they are drugs. So they have implications. Vitamin C can be very hard on the liver when it's given in high doses. Mistletoe can cause like a febrile allergic, it's not an allergic reaction, but like a febrile reaction. So you'll want to be sure to use these with someone who's very experienced in their use, who knows what chemo drugs you're on. Make sure your chemo doctor who's giving you chemo knows that you're on them, so that everything can be coordinated and kept safe. So all of these things are increasingly being asked, increasingly being studied. And I think the only thing we do know is that, or that we can say with certainty, is they can have effect in the body. And so you just want to be sure you do them with full disclosure with your doctor, so and coordination between your naturopathic doctor and your medical oncologist, gynecologic oncologist, whoever's giving you chemotherapy drugs. So the Myriad HRD testing started and got its approval in, I want to say, don't quote me on it. I think it was 2018, but I'm not positive what year. Years blend together. And it is a separate test. So the Myriad HRD includes BRCA1 and 2 somatic testing, but no other gene testing. So some of the companies like Recurrence Foundation One, or if you get the in-house testing with some institutions, like cancer centers or academic institutions, those in-house tests in the foundation and Caris, they also test for a large panel of other genes in addition to BRCA1 and BRCA2. The Myriad HRD is really targeted at this HRD BRCA1, BRCA2 question. And so it's not all-inclusive somatic testing. So platelets. So it is certainly true that the challenge of PARP inhibitors that I haven't mentioned tonight, or the worry with PARP, is the risk of what's called MDS or AML, myeloplastic. I am having a acronym to word problem moment. We're just going to move right on, and I'll come back to that. MDS and AML, which are MDS is sort of the pre-AML, so where it has a blood dyscrasia, so the blood is not being produced properly, and AML is the leukemia version of that, acute myelocytic leukemia. So the worry with PARP inhibitors is always a low but honest risk of developing a leukemia. And so we monitor platelets, we monitor for anemia, and we monitor the white count, 3 markers of this starting to happen. And somebody asked about, their platelets were below 100,000. And so the PARP was stopped because of concern for leukemias. And so then they moved on to Doxil as an option, and they're, watching closely. Now I will say the thing about Doxil is the hematologic toxicities are much less. So that sort of thought process or structure does make sense. And then platelets can be a real bugger, because a lot of the drugs we use need adequate platelet function in order to start them, or they can compromise the platelets, and so we don't want to start with the platelets too low. So end treatment options, I wouldn't say end, but can they introduce a real challenge for your oncologists to come up with a good regimen and keep you on therapies? Yes. Platelets are much trickier than anything else, because with let's think through the other things, right? So white count, we can use Neulasta, we can use Neupogen. We have an intervention for the white count. Anemia, we have an intervention. We can give blood products We can give iron, IV iron, we can give oral iron. So there's an intervention. Platelets are hard. We can transfuse platelets, but there's a limit to the platelet transfusion process, and there's no booster that we can do. There's no Neulasta, there's no Neupogen, there's no iron type of infusion, or rarely used, but Aranesp type of option. So platelets can get very tricky. That's never a situation that we like to encounter, I admit, because it's hard. But there are certainly things you can use even with low platelets, and drugs that are less likely to affect the platelets, like the Doxil. Another result that shows up on all these tests. I talked about gene sequencing results, right? So you can have mutations in genes. You can have some fusion products that are seen in some proteins. And then somebody asked about TMB. And so when you're talking about the tumor molecular burden, you're talking mutational burden. You're talking about how many mutations are present, are present. And some tumors, it's very high. They have many, many, many mutations. And this is great when you're talking about response to immunotherapy. So the low TMB, the low tumor mutation burden, is not HRD. They're actually two separate concepts. And the TMB we use more when we're thinking about response to immunotherapies and using immunotherapies. So one of the things that the comprehensive genomic profiling assays, be that a commercial company or an institution, does is look not only at BRCA and BRCA related, but other genes. And some of those other genes, maybe somebody here tonight, I mentioned the BRCA inherited syndromes. I didn't mention Lynch, but Lynch syndrome is another example of an inherited mutation. When you have your germline testing, almost always in 2021, it's panel testing. And the panel testing actually does look for Lynch syndrome. And just like we can look for Lynch syndrome in the person and their genes, their inherited genes, we can also look for it in the tumor. And so tumor mutational burden or MMR mismatch repair, you'll often see results for that. There's some genes, MSH6, MLH1, that we look at, for instance, and give us a sense of, in the germline setting, Lynch syndrome, and in the somatic setting, what's the likelihood they're going to respond to immunotherapy? And actually, if you have an MMR deficient tumor, be it an ovarian, endometrial, a kidney, a colon, doesn't matter where it's coming from. If you have an MMR deficient tumor, you're a candidate for pembrolizumab based on an FDA approval. So that's like a nice, easy, no question about it, FDA approval. It was the first FDA approval, not based on where the cancer came from, but based on a mutation in the cancer or an abnormality in the cancer, that mismatch repair or MSI abnormality. So our and I think, and so there's that. So the low tumor mutational burden, generally the lowest is the less than 5. So that's the low end number that they put on there. We like to see the 10s or graders. And then a question about immunotherapy clinical trials, and I mentioned immunotherapy. So it's an area where we keep trying. We keep like throwing, I'm missing an analogy right now, but we keep trying to find immunotherapy for ovarian cancer. And we have some narrow windows where we've matched it, MMR deficiency being one. But somebody asked whether immunotherapy clinical trials are always ruled out for people with autoimmune disorders. And I have to say, in my thinking through clinical trials, I do think that immunotherapy clinical trials are often, if not always, and I think always, do not include, let me rephrase how I say that, immunotherapy clinical trials generally do not allow for enrollment by folks who have autoimmune disorders. And that's because of the potential for toxicities. And so I think that's an important element, but that's a safety. Remember I said with clinical trials, you have the people who are running the clinical trial and design the clinical trial, and they submit to data safety monitoring boards and IRBs to maintain safety. And I think certainly as part of maintaining safety, one of the things that we think about in clinical trial design is who's an appropriate patient. We want to make sure we're keeping people safe. And so that would be that would be one question, or one reason, one way to keep people safe. Okay, so in addition to tumor mutational burden, when we're talking about immunotherapy, we can look at PD-L1 as a marker, and generally that CPS score greater than 1 we consider positive, and obviously the higher the better. It's a percentage, so it goes up to 100, and the higher the better. But for purposes of categorization, generally most systems use a greater than 1 as a positive. Treatments for Lynch syndrome. I'm going to say treatments for ovarian cancer related Lynch syndrome. Yes, immunotherapy. Pembrolizumab would be one example of something specific for the Lynch group. The other treatment for Lynch syndrome is prevention. And certainly if you are lucky enough to know about a family member who has Lynch and get tested, Lynch now is no longer, although I talk about it as a syndrome and it generally gets discussed as a syndrome, it's very specific to which gene has the mutation, and the recommendations are specific to which gene has the mutation. And so sometimes we talk to women about risk reducing surgeries for Lynch syndrome as a method of prevention, as well as, if you're particularly young and premenopausal and still wanting to have kids, using things like oral contraceptives to reduce the risk. So let me see. I apologize. Sometimes I don't recognize all acronyms. GEM, that acronym, if somebody can just spell it out for me, I can't cheat and Google it real quickly, which is what I do whenever I see an acronym I don't know, but I'm not able to keep up with the chat and do that at the same time. PARP stopped working. Can it be introduced? Yes, it probably can, based on some recent data from the Oreo trial that we have. So it does look like we have a signal of activity in PARP after PARP, and the possibility for it being reintroduced in the platinum-sensitive setting. So it's still a targeted setting, not indiscriminately, but it does seem like there is the possibility. So let me see if there is any other question. I'm hoping I didn't miss anything. What other conditions are mutations? I think, it's interesting about autoimmune disorders and cancer, or treating gynecologic cancers. Sometimes they get better on the chemo, because some autoimmune disorders are an exuberance of the immune system. The immune system goes wild and sort of attacks the body, right? And so, sometimes actually with cytotoxic chemotherapies, folks feel better when they have autoimmune underlying. I see this most commonly probably actually with rheumatoid arthritis. People who have rheumatoid arthritis will be like, gosh, while I was on my chemo, my joints felt so much better. Not everybody, but a lot of people. So I think there are always medication considerations with autoimmune disorders. You always need, those are medications for things like rheumatoid arthritis, certainly being one example, a good example, where you want to make sure that what somebody's on is compatible with what you're using, and that you dose adjust. So I think probably in addition to just the disease interactions, there is definitely also drug interactions that need to be paid attention to as a primary consideration. There are some autoimmune conditions where we think about cautiously about use. I haven't talked at all about use of radiation. We don't use a lot of radiation in ovarian cancers, but we do sometimes, particularly clear cell histologies. And so there's some autoimmune diseases where you have to be cautious with radiation. I think somebody asked this before, and then I dropped off. Somebody asked, so is the standard of care for frontline ovarian cancer now surgery, chemo, and then a maintenance drug, or do gynocs continue to do a wait and see or fewer NRD after frontline? I would say the answer to this is individualized. I would say for certain cohorts, the answer is very clearly nobody would I don't think anybody would say otherwise. The standard is surgery, a combination of surgery, chemo, and then maintenance. And the maintenance is a PARP inhibitor if you have a BRCA mutation, for instance. If you are HRD negative and have a cancer that they weren't able to completely debulk at the time of surgery, or didn't have the response to chemotherapy, or maybe you started off with some fluid in the lungs called pleural effusions, and they were using Avastin. In that case, some would consider Avastin maintenance a standard of care, treatment option and something to consider. So certainly that would be the case, but I wouldn't say in the frontline setting that use of maintenance is universal. It is a standard of care, but it is not the universal and sole standard of care. And there are some reasons for patients who are BRCA negative, BRCA germline, BRCA somatic, and HRD negative. There are some good, important reasons why a conversation about the use of PARP inhibitors should be had, because the utility in the upfront setting, when you really parse all those trials out, the utility in the frontline setting skews more towards BRCA. And so it's a very individualized choice. I have to say, I wrote a recent editorial on this topic, which fully reveals my opinions on the matter. I'm toning down a little bit and being less clear, only because I do think it is unclear and it's very individualized. But I think it's important to have a conversation about what the true benefits are to PARP inhibitor in different settings, so that you can make a targeted decision about when you're gonna use it. Somebody asked about same kind of question along the frontline setting, chemosurgery, chemo, and I'm assuming that they're asking that in comparison to surgery followed by chemo. We now have multiple randomized clinical trials to say that there is not a survival difference in outcomes if you do chemosurgery, chemo, so like 3 cycles of carbotaxol, then surgery, then 3 more cycles, compared to surgery and then 6 cycles in one straight shot, all at once. So I would say there is good evidence for the chemosurgery, chemo, also known as neoadjuvant chemotherapy approach. And there's one more trial called the TRUST trial that is a multi-institutional international trial that is asking this question. And I think once that trial comes out, that'll be the final trial. We have another 2 to 3 years before we get their data. It's a comparison of its design is designed to make sure that everybody who goes on trial has extremely aggressive surgical cytoreduction. And so there is currently good evidence for chemosurgery, chemo, and sort of one last trial to finalize our conclusion that chemosurgery, chemo is equivalent to surgery followed by chemo, particularly if you have stage 4 disease, for instance, if you have something in the lungs, or if you have disease that's progressed in a way that isn't all removable at the time. So there would be that. Now I know, I apologize. I did not realize when you said Jem that you meant the vaccine, and I should have realized. So thank you for adding that information in. I certainly think it is very intriguing. It's phase 2 data that has come out on the use of the vaccine as a maintenance therapy in the frontline setting. So at initial diagnosis for stage 3 and stage 4 patients, it's only been out less than a year. I think it came out in the results were published, so we could really sort of start to dissect them in January of 2021, I think it was. It was well tolerated. The problem is, I think technically, if you're a stickler, it was intriguing, but did not meet its endpoint, meaning it didn't show the statistical benefit that it wanted to, although it came close. So I think as a maintenance therapy, it is intriguing, but not we're not there yet. So we'll see. Vaccines, there's been a ton of work in ovary cancer on vaccines in the hopes that they would be a great maintenance strategy. New York ESO 1 is probably where some of the greatest amount of vaccine research in ovary cancer has been done. And so we keep trying. We'll figure it out someday. We're just not quite there yet. It's such a complex tumor. There's not a single inlet. Like even the HRD, there's not one way that the tumor cells are HRD. There's a myriad of ways that they're HRD. So it's a challenging tumor type to come up with a single entity, like a single vaccine or a single drug or a single PARP inhibitor target. There's a lot of variability. So I think that's one piece that's out there. The same with the mRNA technologies, and the potential for mRNA technology to help us. It's the same thing. It's getting the right connections, the right hookups, so that it's the right right piece of mRNA that's being used to make the antibody to target the protein, and that there aren't downstream, off-site implications of those. Somebody asked about nutrition. Any interest in nutrition impact? I mean, I think this is a great question. I think there's definitely a role for healthy eating, a well-balanced diet, maintaining the gut in a way that's healthy throughout treatments. So I think that is absolutely critical. I think the other thing I always am very cautious about warning is that nothing to an extreme is good. No diet to an extreme is good. It doesn't matter what the diet is. So a well-balanced diet is very important for sure. Maintaining hydration, not having an excess of, things that you shouldn't have anytime, right? Not an excess of sugar, not an excess of meat, but you can have some of these things without negative implications. And different things, people everybody knows what makes their own body feel good. And so for different folks, the ideal diet may actually be slightly different. I strongly recommend folks check out whether or not their insurance covers a nutrition consult. And if it does, and you live near a cancer center, check out whether or not your cancer center has a nutritionist who specializes in patients with cancer. And I think that can be a real asset for helping you think about what foods are going to be beneficial. And there's a lot of conversation around, different diets and different components of diet, keeping fiber in your diet, mushrooms in your diet, fruits and vegetables in your diet, different things that have nutritional benefits. And so you can actually get an entire degree in how to make it happen. But I think that's why a nutritionist consult is so helpful and so beneficial. So we will do there. Now it's 6 o'clock. I know there's other sessions. I don't want to keep people. Then I can certainly stay and keep asking other questions, but I just looked down and noticed it was 6. So I want to give everybody what's the right phrase, the opportunity to get off and not feel bad about that in any way, shape, or form. So pop off when you need to, and a few more questions. I'll stay and answer for a few minutes more. Milk thistle and calcium, I don't have a strict contraindication to. You do want to check with your oncologist and make sure that there is nothing that you're on that makes them worry about them. Sometimes sometimes they can be hard on the stomach, so you'll just want to make sure that that's not an issue. But there's no strict reason why the milk thistle or calcium is problematic. The keto diet for cancer is one of the ones that comes up all the time. Keto diet, Mediterranean diet, the sugar-free diet, the vegan diet, alkaline in the urine. They are all diets that get thrown out there and can be challenging. They do. And so I would go back to that idea that grabbing a hold of a nutritionist can be important to making sure that you're staying balanced in what you're eating. The keto diet to its extreme can be hard on the body. And part of the goal of the diet is to make sure that your diet is easy on your body. It provides the nutrients, it's easy to digest, it gives you what you need. It doesn't introduce things that tax the body, like excess sugar, right? Anything in excess is what taxes. So So some of those diets I would just be cautious about. Not that there's anything wrong with the keto diet, but it can strain the body in some circumstances. So you just want to be cautious. Any other questions? You can get a copy to re-listen to, and I know there are folks from OCRA on with us tonight. I saw Catherine earlier. I think it gets posted actually in the meeting program, like the online hub for the meeting. And so it'll get posted there and you can re-listen. Anything else? Thanks guys for sticking with us. I hope everybody has a wonderful fall season and good holidays with their families and got some of their questions answered. Good night, everybody.